All right, hello, welcome back to the video. This will be video number 2 for airway management. Today we are going to pick up where we left off, and we left off talking about the combi tube, and supraglottic airway devices. These devices are non-visualized airways or blind insertion devices. They are easy to use. They're not too difficult. They can be inserted quickly. It provides a decent protection from aspiration. They were kind of designed as we call it a rescue airway, meaning if a paramedic or inside the hospital, if you can't get the patient intubated right away, you could actually go to your rescue airway, which would be one of these. Let's see here. So here is the esophageal tracheal combi tube, and you'll see here it has 2 balloons. One balloon is down inferior, a larger balloon's up here. This is the balloon that helps to block off the esophagus to protect the airway from aspiration. This tube down here is kind of, if you get lucky enough to where it actually goes into the trachea, that would be great too to work. But also, if you're in the esophagus, it helps to protect from aspiration as well. So looking at the combi tube, this is what I just showed. Obstructs the esophagus and the pharynx, so the air enters the trachea, just like here. It obstructs the esophagus and the trachea. Unlikely event it enters the trachea, it can still function. It's a good day still. So supraglottic devices, they insert into the hypopharynx. It creates a seal around the glottic opening, pressure applied to force air into the trachea. And then we have the LMA, the King, LTD, the TSD, and the Cobra devices. Here's a King airway. I know here in the cab, we primarily use the LMA. So here is a table. It's in your book, 16.3, the indications and contraindications for advanced AEMT airway devices. You need to know these. So combi tube, what the indication is. Here we have unresponsive without a gag reflex. Okay, and requires a more secure airway route of ventilation that can be provided by more basic means. Here's some contraindications right here. Patient is under 5 feet tall. A small adult size exists and can be used in patients between 4.5 feet to 5 feet. But unless you have that, the relative contraindication here is someone who is 5 feet tall is, or someone under 5 feet tall is a contraindication. Patients under 16 years of age. Presence of esophageal disease or trauma. Or someone who has a stoma, you couldn't use that. It'd be contraindicated. The LMA, this is the indications for the LMA. Patients unresponsive, again, without a gag reflex. It provides a more secure airway and route of ventilation that can be provided by more basic means. The contraindication, no contraindications for use as a rescue airway in patients who are completely unresponsive and they do not have a gag reflex. Again, also, if they have a stoma, we should be ventilating through that. The King airway, the indication, again, unresponsive without a gag reflex. Contraindications is intact gag reflex, or they have a stoma. Once the airway secured, assess need for artificial ventilations. Right, so BVM if the patient has absent or inadequate breathing. Pressure supported ventilation, otherwise known as CPAP, assisted patient approaching respiratory failure. And they may improve oxygenation enough to avoid intubation. So thank God that we do have CPAP, because prior to CPAP, if you were in congestive heart failure and you were in respiratory failure, we would nasally intubate you with an ET tube. And nowadays, you don't ever see that, because CPAP is taking that away. And it wasn't an easy job to nasally intubate somebody. So I'm glad that we have CPAP. Ventilation. So someone who needs supplemental O2, and it says guided by pulse ox. So again, we use that pulse ox as just a guide to confirm our suspicion of failure versus not failure, or it gives us an idea of maybe how bad off the person is and how quickly we may be approaching failure. Severe respiratory distress, failure, or arrest. All right, supplemental spontaneous respiration effort or provide artificial ventilation. All right, so basically CPAP, or we're bagging them if they are in respiratory failure. Here's a CPAP device here. Positive pressure ventilation, PPV. Inspiration generated by negative inthoracic pressure. Remember that negative pressure that we talk about, the atmospheric pressure. When that chest cavity becomes more negative, that's when we're drawing air in. We're created a vacuum. If that patient can't create that vacuum anymore and can't bring air in down to the alveoli, then we're gonna have to use something like a bag valve mask in order to get that get that oxygen down to the alveoli. So when we look at a BVM, just as a review, self-inflating bag attached to a mask. Air expels from the mask when the bag is squeezed. It obviously can be used with oxygen. We have different sizes: adult, pedi, infant, and even neonatal sizes. It does require that the airway's open. If we're ventilating and the airway's not open, obviously we're not getting oxygen down to the alveoli. It does require a proper fitting mask, and we have to ventilate at the appropriate depth and rate. It's so important. It's so important because if you obviously if you don't have at least 1 inch of chest rise and fall, then it's not working. But the rate seems to be a problem. It's a problem in the field. It's a problem inside the hospital. 1 breath every 5 to 6 seconds. If you're bagging any more than that, then we're running the risk of increasing intrathoracic pressure. And what that does is it causes blood returning to the right side of the heart through the inferior vena cava not to get there. It slows venous return. And if you have a patient you're coding, and you have no blood pressure, you're not helping them. Matter of fact, you're making it worse. It's super important that you keep up with the 1 breath every 5 to 6 seconds and don't hyperventilate that patient. All right, so here is just a basic BVM. You're all familiar with it. The face mask, the exhalation port, the non-breathing valve, ventilation bag. I know that back in the day, they actually had something on here that would help you to increase what they call PEEP, and we'll talk more about that here in a second. But yeah, and so you see the different sizes. So ventilations achieve a good mass seal. The bag is kind of designed to be used with 2 people. However, in common practice, we utilize it with 1. We need to remember your EC technique to achieve the proper mass seal. Just like I mentioned earlier, PEEP valves, it helps to prevent alveolar collapse during positive pressure ventilation. PEEP valves, it's kind of built into the BVM, but you used to actually be able to adjust it. But it allows those, if you're putting more PEEP into the equation, then you're allowing those alveoli to stay open just a little bit longer for gas exchange. We need to also, again, the depth, we talked about that, how important that is. So we have the 2 people providing BVM, one's holding the seal while the other one bags. So indications of effective and ineffective positive pressure ventilation. Well, there is some things here that you can look at, but at the end of the day, it's all about your mass seal, and it's all about looking for at least 1 inch of chest rise and fall. That's what we have to have. It's not complicated. I will tell you this, down here it mentions patient condition fails to improve or deteriorates, and you can see mental status, and that's your number 1 sign of hypoxia, is when you have a change in mental status. But you can look at the skin color. We were coding a patient at the hospital the other day, and it was a witness cardiac arrest inside the hospital, and we normally are able to turn those around, and this patient we actually couldn't. We coded him for about an hour, and about 35 minutes into it, I looked at the doctor and I said, his color is just terrible right now. And so, the patient was intubated and did have good chest rise and fall. I think we just had some poor CPR, but even then though, the longer you code a patient, the death is coming into the equation. The longer you don't have ROSC. And so, but all of those are, if you can train yourself to be observant and look for these, it will lead you down the right road. I'll show you a picture of it in a second. Let me show you the picture first. Here we have a flow restricted oxygen power ventilated device. And we used to have these years ago. And it has a button on it, and you would hold the seal and you would push that button. What do you think the problem here with this was? Yeah, we were popping lungs. You can't, as soon as you see chest rise and fall, you're supposed to let off that button. But if you held it on, guess what? You could pop a lung. It was that much pressure involved. So we don't see a lot of these, but they were really good though. They were not, if you just had to pay attention to what you were doing. This is a manual triggered ventilation device, and we'll talk about the automatic transport ventilator in a second. Delivers positive pressure without the provider needing to squeeze the bag. In a second, I'll show you the vent, but you set a rate and volume of ventilations and uses power of compressed oxygen to deliver ventilations. So this is a transport ventilator, and it's a lot different than the one I just showed you. This you can set the tidal volume, you set it to adult or child here, and this is breaths per minute. And so depending on what you're trying to achieve, if you have somebody, maybe you have a diabetic ketoacidosis patient and we want them to breathe off CO2, well, we'd set that at 20. But if you were working anything else, 12 breaths per minute, 10 breaths per minute would be acceptable. So ventilation, automatic transport ventilator, patient required bag valve mask delivered by devices, hands-free operation, and you set the rate and volume of ventilations. These are great. They're compact. They're very portable. We use them at the hospital when we're taking someone over to the CT that needs to go through the CAT scan. We just put it on the stretcher on the patient. We can send them through CAT scan, and it ventilates them. Now, again, they do break. I was privy to one that didn't work, and so at the end of the day, you can't just hook one of these up and assume that they're gonna work. Again, you have to make sure you have good chest rise and fall. It's so important to look at your patient. You're looking at their color, right? You want to make sure that there's no color change. Usually these patients are sedated if they have a pulse, and we just have them intubated. So we can't look at mental status in this case, but we can look at the color of the patient. We can make sure there's chest rise and fall, and you can look at your pulse ox and your end-tidal CO2 to make sure that everything's going well. It's continuous positive airway pressure, CPAP. Positive pressure to improve airflow, spontaneously breathing patients. It was designed for pulmonary edema. Do we use it on other things? We do. But you got to be careful because it was designed for pulmonary edema. With asthmatics, we got to remember here, we have bronchial constriction is the problem. And so hopefully if you use CPAP, you could maybe force a volume of air through using pressure. But we have to fix the bronchial constriction before we're going to get improvement. All right, back to you. Sorry, I had to put you on pause there for a sec. All right, so when we're talking about CPAP, again, you kind of got to think about what you're using it for. The other thing is it's not a ventilator, okay? Now, it will almost work like one. If I've had patients that were pulmonary edema patients who we would put CPAP on, and they would slide into failure. And the problem there is their airway can become blocked. Remember, there's no oral airway there. There's nothing holding that tongue back from causing an airway obstruction. So they have to be able to maintain their own airway if you're going to use CPAP. So that's just, you're going to have to remove them from CPAP if they go into failure and start bagging that patient using the oral airway. And if they have no gag reflex, you can put an advanced airway in. It's used to improve ventilation is already taking place, only in patients responsive and able to follow commands. Like I said, if they lose the ability to follow commands, they don't respond to you, then it's time to start bagging that patient. So mask seal, we talked about it. It's essential for your BVM. Choose the appropriate size mask. Don't forget your EC grip. And remember, it was designed to be used with two providers. If you're not getting good chest rise and fall, you might have to ask for assistance. Oxygenation. All patients with complaints of dyspnea who are in respiratory distress or failure or rest should receive supplemental oxygen. That's a no-brainer, right? Oxygen is beneficial to those patients who have a pulse ox around 94 to 95, depending, right? Remember, oxygen is a drug, And we don't want to just be giving it out unless we need it. So look at the side effects and the mechanism of action for oxygen. It's a vasoactive drug. It can decrease perfusion at times to ischemic tissues, right? And so remember, like patients who have brain injury, stroke, or even MIs, right? You can actually cause damage by over-oxygenation these patients. So we want to live on those patients somewhere between 94%. We're good with that. So hyperoxia, or that means too much oxygen, increases morbidity and mortality and resuscitation from cardiac arrest because we're hyperventilating them. We're hyperventilating them and we're reducing venous return because we're increasing into thoracic pressure. Something to think about. We cranked that up to 25 and go to town on bagging somebody, and we killed a lot of people with those practices, and we've learned from our errors, and so we just have to provide good treatment in the field. It can dry and irritate mucous membranes, but again, never withhold oxygen from a patient who needs it. I remember, if you think about it and the science behind hypoxic drive, basically, if you have someone who is a COPD patient and they're on hypoxic drive, well, in theory, if you had them at 100% oxygen long enough, they would stop breathing. And they've done a study on that. It's not very conclusive, but with science, right? So we used to have these Venturi masks on the truck, and we're supposed to use them back in the day for COPD patients, and but we were withholding oxygen from people who needed it. So at the end of the day, if you have a COPD patient, you have someone who's in distress, it doesn't matter. Put them on that non-rebreather and provide oxygen for them. You're not going to hurt them, but you will hurt them if you withhold it. So when do we use oxygen? Well, all of these, right? Cardiac arrest, respiratory failure, patients who need ventilating. It's self-explanatory when we're going to need it. How we use it isn't always self-explanatory. Can we use it too much? Yes, we can. So, you're familiar with O2 tanks. I'm not going to spend a lot of time here on this because you're all licensed emergency medical technicians, and you should know at this point how to set up an O2 bottle with a regulator. You've already put oxygen on people, I'm sure. And so you should be familiar with all of these. Here's that Venturi mask I was telling you about. And there used to be like a little knob here on the bottom. You could set the rate, your FiO2, to what you wanted it to be. Let's look at this. So just to review, 1 to 6 on nasal cannulas, a simple face mask. So this is without the reservoir. Looks like a non-rebreather without the reservoir. 6 to 10 non-rebreathers. 10 to 12 flow rate must be adequate to keep the reservoir bag inflated. And so you want to always make sure that bag is at least inflated by 1/3. 1/3. All right, let's see here. Review the trach mask, because we don't use those every day. 8 to 10 liters per minute. And there's a trach mask. Okay, so let's just cover the summary real quick. Without adequate airway ventilation or oxygenation, the body cannot perform normal cellular metabolism. Without adequate internal and external respiration, hypoxia quickly ensues. Each patient has an open airway. Ensure each patient has an open airway, that you're adequately ventilating the patient, and that the patient is adequately oxygenated. Immediate problems with airway and breathing address in a primary assessment. A variety of manual airways, maneuvers, and basic airway adjuncts. Foreign body airway obstruction maneuvers, suction, oxygen, bag valve mask device to restore and maintain airway ventilation and oxygenation. You may use a commie tube or supraglottic airway to assist in airway management and ventilation, as long as they don't have a gag reflex and there's no contraindications. Finding correctable underlying cause for impaired airway breathing, preferable to continue airway management. And alert patients can protect their airway better than you can protect it with a mechanical device. Ensure you're applying techniques correctly to minimize complications. The goal of airway management, positive pressure ventilation, oxygen administration is to what? To prevent hypoxia. And always use the findings of the patient assessment, clinical judgment, critical thinking to treat your patient. That is it for this chapter. I have another slideshow that I'm going to put up that just kind of talks about the same thing, but a little different. Comes from a different book, because we can't just rely on our one book. We have to really look out to other things too. All right. This is video number 2 for airway. Remember, I screwed up on the syllabus. It's chapter 16 on airway. So I think Izzy just called me to tell me this. So thank you, Izzy. All right, guys. Talk to you later.